Okay, hello everybody. Thank you so much for joining us for today's webinar. This is part one of our CTC training webinar series, and this presentation is going to be focused on how to benchmark your practice and help advance the field. The learning objectives for today's webinar are going to be first to determine how participating in the CTC registry helps the radiology community learn from each other, benchmark our practices, and collect data for advocacy. We will identify key data elements and how they populate CTC reports and quality measures. And we will recall knowledge from a case example to begin to operationalize CTC registry participation at your institution. I'm your moderator today. My name is Zach Smith. I'm a Senior Quality Programs Assistant at ACR for the Quality and Safety Department. And I'm joined today by our speakers, Courtney Moreno. Courtney Moreno is an associate professor in the Department of Radiology and Imaging Sciences at Emory University School of Medicine. She chairs the CTC Registry Committee, one of 8 registries that comprise the ACR's National Radiology Data Registry. We're also joined by Kevin Chang, who's the director of MRI at Boston University Medical Center and is an associate professor of radiology at Boston University School of Medicine. Dr. Chang is a member of the CTC Registry Committee. We're also joined by Dr. Vasantha Vasan. She's an associate professor of radiology at UT Southwestern Medical Center and a member of its abdominal imaging division. Dr. Vasan also serves as a member of the CTC Registry Committee. And we're joined by Thomas Law, RN. He is a patient navigator at UT Southwestern Medical Center and works closely with Dr. Vasan in carrying out activities related to their participation in the CTC registry. None of our speakers today have any disclosures. So with that being said, I just want to go over a few housekeeping things before we get started. If you want to type any questions in, there's a Q&A box here. You can also comment or ask questions in the chat box. If you comment in the chat box, everybody can see it. If you comment in the Q&A box, only the organizers can see it. And we should have some time at the end for Q&A, so we can answer your questions out loud at the end. We can also possibly have you raise your hand if you want to ask a question out loud if we have enough time. So before we hand it over to the speakers, I wanted to do a quick poll. We've got 2 polls here. This is the first one. This is the second one. You should see them come up on your screen right now. So the first question is, what is your role at your institution? The second question is, what practice setting do you work in? So we'll give everybody a minute to answer these. Okay. So I'm sharing the results real quick. It looks like we've got a pretty good variety of attendees here. We've got radiologists, technologists, administrators, lots of administrators on the webinar. And as far as the practice setting, mostly private practice and academic institutions. So thanks everybody for participating in that. Okay, so now I'm going to hand it over to Dr. Chang.
All right, great. I'm just going to give a quick update to the current state of CT colonography and talk about the current colorectal cancer screening recommendations in the US. So we'll go on to the next slide. So the American Cancer Society last updated their recommended screening option list a couple years back. Pretty recent update that included a drop in the screening age threshold for average risk individuals to the age of 45. And that they divided their list of screening options into 2 major categories. Now, those are tests of prevention, which are designed mostly to detect polyps and cancer. So these ones can detect the precancerous polyps before they become a cancer. The choices there include a colonoscopy every 10 years. They include CT colonography every 5 years and flexible sigmoidoscopy every 5 years. And basically the CT colonographies largely replaced the double contrast barium enema that used to be on this list. And then the second category are basically the stool-based tests, which are more designed to detect cancer rather than a polyp. And that includes fecal occult blood tests, the FIT test, and stool DNA tests, also known as a Cologuard. The U.S. Preventive Services Task Force last updated their recommendations in 2016 and divided their tests into similar categories, of which you can see the CT colonographies included on their list of direct visualization tests. And they recommend every 5 years there as well. Next screen. And during their last recommendations, they gave a grade A for all the tests on that previous list for adults aged 50 and over. And then for those that are older than 75, they gave a grade C, basically saying that the decision to continue screening depends on the expectations for the remainder of their life expectancy. On the next slide, you can see the draft recommendations that were released last year, which I anticipate will get finalized at some point this year, now includes a grade B rating for those between the ages of 45 and 50. So this hopefully will increase or will also confirm what the American Cancer Society recommended and recommend screening for those under the age of 50 as well with a grade B. And similarly, the same recommendations for patients older than 75. Currently, in terms of insurance coverage for CT colonography, it differs between private payers and those covered under Medicare and Medicaid. Currently, private payers are mandated by the Affordable Care Act to fully cover any recommended screening options recommended by the U.S. Preventive Services Task Force, which includes CT colonography. And many payers, including the top 5, covered this even before the Affordable Care Act was passed. So that's for screening purposes. For incomplete colonoscopies and contraindication to colonoscopies, these are 2 indications that are covered by both private payers and, on the next slide, by Medicare and Medicaid. But currently, Medicare and Medicaid still only cover diagnostic CT colonographies for these 2 indications, for either an incomplete colonoscopy, which can be performed on the same day as the colonoscopy, unless the reason is for inadequate prep, or on a separate day, or for anybody with a contraindication of colonoscopy, including anticoagulation, difficulty with prior colonoscopies, difficulty or high risk for sedation, etc. In terms of how it's performed, there's one question on the registry that asks about whether the guidelines, the technical parameters of the CT colonography satisfy the ACR recommendations. I'm not going to go over the details now, but you can consult the ACR white paper online if you want to see what the guidelines are. Next slide. And I'll give it, I'll pass the mic over to Zach to do our next poll. Thank you.
Thank you. So we've got a couple polling questions here, and I'll launch those in just a minute. We're first going to ask about what your current participation status is with CTC, and then we're going to ask if you participate in any other registries. So give me one moment. I'll launch that. Okay, hopefully everybody can see these polls here. Okay, I'll give it just a little more time. Okay, it looks like we've got a pretty good number of respondents here. So let me end this and I'll share the results. Looks like most of the people here are either enrolled and submitting data already, or they're not enrolled at all in CTC. As far as other registries that people are participating in, we've got a few people in GRID, DIR, and then it looks like a lot of people in the LCSR. All right, thank you again. So now I believe we're handing it over to Dr. Moreno.
Yes, thank you, Zach.
Thanks.
So I'm going to speak briefly about the data fields that we are collecting in the registry. Our registry committee has been hard at work over the last approximately a year working to simplify the data fields that we are collecting based on user feedback. So these new forms went live in December of 2020. Information that we collect includes demographic information such as age, gender, race, and ethnicity. We also collect information that's exam related. Specifically, was it a screening CTC or a diagnostic CTC? We ask if it was performed following an incomplete colonoscopy. And then we do have other exam related variables such as were the acquisition supine, prone, or decubitus. For those of you that have been participating in the registry for several years, you may recall that there used to be even more fields. For example, there used to be a field looking at the section thickness of the exam. There was another field with vendor name. We've really tried to simplify and remove some of the kind of extra fields to make it easier for folks to enter the data. Instead of asking about a lot of specific technical parameters, as Dr. Chang mentioned, there is a field where we ask, was the exam performed in line with the 2019 ACR white paper and the recommendations in that paper, and the reference for that paper, it's available on the registry website. In addition to these items, we also still ask the CRAD score, specifically the C score and the E score, as well as whether or not there was a perforation. And we do have a field where you were asked to submit the dose measure CT diavol. Additionally, we also simplified the polyp level data. Those of you who participated in the prior iteration of the registry, you may recall that there were separate forms where you could provide polyp level data on every single polyp that was seen. We received feedback from users that that was somewhat tedious and also not possible for all sites. If you have a lot of patients that are referred to your site from the outside and perhaps you don't have access to their follow-up records, that was a challenge. So we wanted to make that easier for people to participate. So what we've done is we've pared down the polyp data to asking, was there at least one polyp that was greater than or equal to 10 millimeters in size? And this is because this size is a threshold for clinically polyps that are generally considered to be clinically significant and for which colonoscopy is typically recommended. And then we ask, was the polyp confirmed at optical colonoscopy or surgery? And then we ask, we've added an option, where folks can indicate that it was a patient referred from the outside and you don't have access to the records to know if the colonoscopy was performed. And then there's also a field where you can indicate the histology using checkboxes of any polyps that were confirmed. Next slide, please. Here are the outcome measures that are reported back to you. So with registry, so you would submit your data and then the ACR tabulates these outcome measures and reports them back to you. So one of them is rate of colonic perforation, true positive rate, and then also we report back clinically significant extracolonic findings. And one of the reasons that we're focusing on these outcome measures, as Dr. Chang mentioned, although CTC is covered by commercial insurance carriers as mandated by the Affordable Care Act of 2010 based on its grade A from the United States Preventive Services Task Force, unfortunately, Medicare still does not cover CTC for a screening indication. And those of you that are in this space, I'm sure we've all had the sad cases of folks that want to get a CTC, but they have Medicare and are unable to afford the out-of-pocket expense for a screening CTC when Medicare won't cover it. So when Medicare wrote their coverage decision, these were some of the areas that were cited as areas for which more information was needed to try to sway Medicare's opinion to please cover this exam. So thank you for those that are already submitting data, and for those of you that are thinking about it, I encourage you to please do participate in the registry so we can collect even more data to better advocate for Medicare coverage and other advocacy efforts to try to expand CTC access and colorectal cancer screening access. Okay, next slide, please. There are many benefits to you as a participant in the registry. You will get semi-annual reports from the ACR. I'll show you some examples of what those look like. Additionally, for researchers on the call, you get free access to registry data and assistance from an ACR analyst. We'll go through that a little bit more in a few slides. Additionally, for radiologists on the call, participation in the registry satisfies Part 4 of the American Board of Radiology Maintenance of Certification requirement. And additionally, you get a snazzy marketing toolkit, which we'll show you some examples of. Next slide, please. So here is a sample report. This is what the reports look like. Next slide, please. You will get an overview of where submitting sites are that are participating in the registry. So I will brag on our site, Atlanta, Georgia, UCR dot, and we're so fortunate to have a wonderful coordinator, Lucian McKinney, submitting our data for us. So it gives you a neat overview of where in the country people are participating in the registry. Next slide, please. Additionally, you can see an overview of the types of facilities participating in the registry. You can see the range of academic, community, or freestanding sites, the metropolitan, suburban, rural distribution. You can also, if you're curious about the number of exams that other facilities are performing, you can see the distribution for the submitting facilities as well as the geographic distribution. Next slide, please. Additionally, you will receive benchmarking data. So this is one of the charts from the report. Again, this was a sample report for a sample facility showing up with the blue columns compared to the overall registry data showing up with the red columns. You can see on the right side of the screen the data for colonic perforations, which fortunately is 0, which is what we would expect, but great data to still collect for our advocacy efforts, especially as it relates to Medicare coverage. You can see how your site benchmark it against the registry data for true positives, as well as for clinically significant extracolonic findings, which is computed from the E-score that you submit. We count E3 and E4 scores as clinically significant. Additionally, on the left-hand, I'm sorry, Zach, could you go back, please? Sorry. On the left-hand side of this screen, you can see where we've got information for your site, as well as the rest of the registry data about adequacy of bowel cleansing and distension, which we get from the C-score, as well as the adequacy of screening and diagnostic exams. And this, as Dr. Chang mentioned, is based on you indicating that it was performed in line with the ACR practice parameter. Again, for those of you that aren't participating in the registry yet, there's no actual image submission. You're not submitting your images to us. It's data that you're submitting, and Dr. Bassan and Thomas Law will go through that in a few slides. Okay, next slide, please. Additionally, in addition to the chart form, you will get graphs of all the different process and outcome measures. This is just one of the process measures graphed over time to see how your facility is performing over time and improving. Next slide, please. And then a really, really neat benefit is that when you participate in the registry, you get free access to registry data, as well as help from an ACR analyst. This is a project that was recently published from ACR data, looking at the impact of Medicare's non-coverage on CTC utilization, where we found that utilization really dropped off once people hit 65, which is Medicare age, and it especially dropped off in African-American patients and other minorities. So there's so many projects that you could do with the registry data, and we really want to encourage people to utilize it. If you do want to work on a project, there are forms to fill out to request the data, and then you indicate to the ACR analyst the types of data tables that you would like, and then the ACR analyst will provide you with those tables. So I just think it's a tremendous resource, especially for any researchers that have joined the webinar. There are just so many neat projects that could be done. Okay, next slide, please. Also, for radiologists on the call that are participating in the ABR's MOC program, participation in the CTC registry satisfies the Part 4 requirement. So it's just a quick and easy way to be able to satisfy that requirement. Next slide, please. And for all of our participating sites, you have access to this great marketing toolkit. So you get graphics files that you can use for your reporting, for letterhead, for your website. You get customizable ad templates that you could use for print or web-based advertising. And then you get these neat signs that you can customize to your specific location and put them out in your waiting rooms, or set them out at your facility, just to let people know that you are performing CT colonography. Next slide, please. Additionally, you will receive this customizable press release that you can use to spread the word at your facility or in your local area that you are now offering CT colonography and that you're also participating in this quality improvement database. Next slide, please. And my final slide here is about cost. So it looked like from the survey that several folks are already participating in the ACR's Dose Index Registry or the General Radiology Improvement Database. If you're participating in either of those databases, then it's free. So that's terrific that it would be free for many of you all. And then if you are participating in the CTC registry in isolation, then the pricing scale is based on the number of submitting sites and the number of radiologists, starting at $500 per year for between 1 to 5 submitting radiologists and 1 to 5 sites. So I believe that is my last slide, Zach. Thank you. Next up will be Dr. Vassan and Thomas Law, who will teach us about how they've been able to operationalize participation in the CTC registry at UT Southwestern. Thank you.
Thank you. Good afternoon, everyone. I am an abdominal radiologist, and I've been reading CTCs for approximately 7 to 8 years now. And I am from the University of Texas Southwestern Medical Center in Dallas. In the next few minutes, I will give you a brief overview of our practice of CTC at UT Southwestern. So being an academic center, we have a wide range of cases that range from just asymptomatic outpatient screening to more complex inpatient cases. Our hospital has a robust transplant service, and therefore we get a good number of cases or patients who are unable to undergo optical colonoscopy, and they get CT colonoscopies. So our volume, I would say, it varies from month to month, but on average, it's about 2 to 3 cases a week. Our group of radiologists who read CTC are 4 in number, and they are all been entered into the registry. Next slide, please. So colorectal cancer screening is a team approach. We have partnered with our gastroenterologists in creating a screening program, and and we use a patient navigator as part of that. You will hear from Thomas Lau, who is our patient navigator, who helps us with multiple parts of this program, one of which is entering the data into the registry. But Thomas is, he helps us with scheduling patients and also educating patients on bowel preps, not only for the CTC, but also for traditional colonoscopy. And because he's well-versed with both procedures and understands the workflow on both sides, he's able to quickly troubleshoot. He also has the okay from the gastroenterologist to offer patient CTC if he perceives someone to be hesitant to get optical colonoscopy. In general, I'd say having someone like a patient navigator or a lead tech has helped us a lot to streamline and smoothen the workflow for us, and actually has also increased our volumes since Thomas joined our team. Next slide, please. Okay, so our CTC report is dictated using a template, and the template is pre-populated with a pick list choices of all the data that is required for the CTC registry. So here is a sample of just a part of the report of the template, and each of the spaces between the brackets gives you a pick list of options. So as in this example, which is shaded in blue, so one of the required data to be entered into the registry was there perforation or not? And so by entering it into this report, we make sure that it is consistently available every time. So the template standardizes the report, and it also simplifies data extraction on the back end of it. So when Thomas goes in to get the data, he can consistently find what he wants to find at the same location without having to search for it. So spending some time on the front end and creating a dictation template will save some time when it comes to data extraction. Next slide, please. So as Dr. Moreno indicated, participating in the registry, we get periodic feedback reports about how our facility is performing and also how the individual physicians are performing. And it is compared to the registry as a whole. So we get feedback on two things. One is the process itself regarding the adequacy of the study. And also the other is the outcomes, as Dr. Moreno indicated, if there was perforation, the true positive rate and the extracolonic findings. So periodically looking through these reports helps us make sure that our performance is adequate, and it also helps in the early identification of any areas that may need improvement. I'm going to hand it off to Thomas, who's going to talk a little bit about how the data is entered. Thank you.
Thank you, Dr. Basan. Hi, everybody. My name is Thomas Law. I'm an RN, and I am a colon cancer screening patient navigator at UT Southwestern. I want to take everybody through kind of a high-level overview of our data submission, and it does start with the navigator at UT Southwestern. Even before we get to the scheduling, the radiologist and the CT techs, we communicate through email. We have a group email, so if there's any questions regarding these patients who, like Dr. Basan said, a lot are high acuity transplant patients, we can email each other and get this taken care of up front. But once I see that the report has become available from the radiologist, we have a tech work list in our EMR that I'm able to see when the report has been completed. I actually see all of our CT colonography reports when they're done, when they're completed, and when they're finalized. So once they're finalized, I'm able to manually upload that or load that data from the EMR to an Excel spreadsheet. And all this information for this Excel spreadsheet is on the NRDR website, and they have the data points that are required and those that are optional and the reasons why, so you get all that information. And then once I put that data into the spreadsheet, I create a file that I'm going to transmit to the NRDR website, and you can see an example of it at the bottom of that screen. It's a text file format that's, and you can go to the next slide. It's called a text tab delimited file, and we upload that directly into the NRDR website. So once you create that file, you just have your file folder with those in there. You pick the one, you browse it, upload, and then you select that file. It typically takes about 3 days before that particular case becomes an exam, or that it's completed in the NRDR website. And then at that time, you can update that exam as needed. And you go to the next slide, please. So any submission for follow-up data, for like follow-up cases, are going to be completed through the exam form, especially if you don't have that data up front. Now, I like to submit our data on a case-by-case basis, so I don't hold data in place. What I mean by that, so if I get a case that's completed, the CT colonography is completed, I don't wait for a colonoscopy or any other follow-up. I go ahead and submit that data to the NRDR website, and then I can update that exam in the future as need be, whether they have a colonoscopy, et cetera. And you go to the next slide, please. And I follow up on those positive cases, usually about twice a month. It can be sooner. It's usually based on that ordering provider's recommendations, which is based on the radiologist's recommendation. We do, like Dr. Basan said, we have a lot of transplant patients, a lot of high acuity patients who may need the transplant prior to having the colonoscopy. It's, they may have the colonoscopy a year after they've had the colonography. I keep them in my database to follow up on, to make sure that that colonoscopy is completed and that we get that data and we submit it, or that surgery, or whatever the case may be. So we don't have a specific time frame for data submission because each case is subjective, or subjective to the patient's needs. I follow closely with the providers and communicate across the campus with all of our transplant teams and primary care physicians on the needs for that patient for upcoming testing. And like what Dr. Bassan said as well, I can schedule colonoscopies. And with that, I will pass it along.
Thank you, Thomas. This slide is letting you all know about the registry startup guide, which is available on the ACR website. I think Dr. Vassan and Thomas did a wonderful job of walking us through the basics of how they do the data submission at UT Southwestern. If you're looking for additional details, this would be a good resource for you, especially those sites that aren't yet submitting to the registry. And I see that Lisa has put a link to the startup guide in the chat. So thank you, Lisa, for doing that. So I will kick it back to Zach, and I think Zach is going to tell us in a few slides about it, a second webinar, the second part of this two-part series that will also be even more detailed about working with the registry web forms. Thank you.
Thank you. Okay, so we've got just one more poll before we move into the wrap up and Q&A section. So this is for people that are not currently enrolled. Let me just pull this up. So if you're not currently enrolled or not submitting data right now to the CTC registry, how likely is your facility to participate within the next year? I'll give everybody a minute for that. Okay, thanks everybody. Oh, we've got some very likely, some not sure. So thanks everybody for participating in that. So I just wanted to talk a little bit about the NRDR knowledge base. Dr. Marino touched on this a little bit, but this is a website that we have. It's also, some of you may be familiar with it if you're MIPS users or use any other registries. If you ever need to open help desk tickets with us, this is the same website where you do that. It's just nrdrsupport.acr.org. And there's also an email address associated with it, which is just nrdrsupport@acr.org. But basically, we have all of these articles written about all of the different registries, and they encompass, how to submit your data, what measures are available for each registry, how to view your reports for each registry, and pretty much anything you would need to know, both about getting started, getting set up with the NRDR, and about once you start submitting data, how to actually use that data and how to view your reports. So in addition to that, we've also got the just general ACR website, acr.org/NRDR should take you to the page with all the registries, and you can see the link to the CTC there. And there's lots of useful information on that page as well. Now this screenshot on the right-hand side here is what you'll see when you actually log into your NRDR account. And this is where you can see how to access your forms, your reports, and things like that. So with that, I think we can move on to the Q&A. I know I've been seeing some questions come in throughout the presentation, and we've got some people that have been monitoring those. So Lisa, if you've got any questions that you want to start reading out loud, and anybody that has any questions, feel free to enter them in the Q&A box and we'll read those out loud as soon as we can.
Sure. There's one asking, how is the reimbursement for screening CTC for pre-transplant patients?
Dr. Vasan, could you speak to that, please?
Yes. So as long as most of these patients fall under the diagnostic CTC, because diagnostic CTC is reimbursed by both Medicare and also the private insurers, because these patients are unable to undergo colonoscopy due to anesthesia risk. Similarly, if you have anticoagulation and you can't undergo, so they are unable to undergo regular optical colonoscopy, and therefore they are reimbursed.
Thank you, Dr. Vasan. There's another question. At UT Southwestern, are they speaking of fecal transplant?
Of what? Fecal transplant? Fecal transplant. I'm sorry, I didn't hear you.
Fecal transplant.
With regards to Crohn's disease, I've heard of it, but I'm not sure I really know much to talk about that.
We're talking about transplant patients who are up for heart transplants, liver, kidney, and lung. So these are our transplant patients that are high acuity, that are having colonographies, and in lieu of having a colonoscopy much of the time.
And this is Courtney Moreno. I'll just chime in that we also, we've done a few at Emory for that same situation of hospitalized inpatients that are thought to be too fragile for optical colonoscopy, who will undergo a screening CT colonography as well. But to reiterate what Thomas says, it's just to clarify, it's not the CTC before a fecal transplant, it's the CTC to clear them to undergo a solid organ transplant.
Yes, thank you.
Thank you.
Well, that's all the unanswered questions that I've seen. If anybody in the attendees would have any other questions, feel free to just type them in the chat. Or I suppose we could use the raise hand feature and unmute you, I think we can do, so you can ask a question. Oh, another one just popped up. We struggle with the ICD codes to use for pre-transplant patients. Use the diagnostic exam code with 2 ICDs for Medicare.
Yeah.
What 2 to use, she asks.
I'm not sure I know the exact code, but I do know we use the diagnostic code for the transplant patients, pre-transplant patients. But I can find out a little bit more and get back regarding the exact code number, etc.
Thank you, Dr. Vasan. I'm not aware of the specific ICD codes either, but thank you for looking that up for us. I am seeing a question about, is ACR planning to engage Epic to see if there's a way to extract the data directly from Epic? I think that's a wonderful idea, and that's something certainly that we can work on. I don't have an ETA for that. I don't know if anyone from the ACR can speak to that.
Hi, this is Judy Burleson. I can, and maybe Lou and or Mike may have additional thoughts. That can be done now. There's not a relationship with the Epic for the CTC registry as there is for lung cancer screening or for breast cancer screening registries, in terms of their Epic having built modules like that. But the data can be submitted electronically through web services or file upload. It just would have to develop a query from Epic to pull out the data elements that are needed for the registry.
Thank you, Judy. Is that something that would be covered in the startup guide or possibly the second webinar if people would like more detailed information on that?
Yes, we intend to do that.
Okay, wonderful. Thank you.
I don't see any other questions. Oh, of course, as soon as I said that, one popped up. Is there any new funding sought planned for more national awareness of colon health? Breast always wins.
I know that the ACR Colon Cancer Committee, led by Judy, is hard at work advocating for CTC in every way possible. Let's see, in terms of this specific question, also know that there's lots of efforts going on by the Colon Cancer Foundation during March, which is the Colon Cancer Screening Month or Colon Cancer Awareness Month, as well as the American Cancer Society. Other panelists, please feel free to chime in on this one as well. Let's see. Oh, another thing to highlight for those of you on the call, a way to raise awareness about CTC is there's a great CT colonography locator tool on the ACR's website. So for any practice, anybody logged into the webinar who hasn't signed your sites up for the CT colonography locator tool, I would encourage you to do that. I can, as soon as I stop talking, I can put the link in the chat so that you all see it, but it's free for everybody. Even if you're not an ACR member, you can register your site. And then when patients out there are looking for to find a place that does CT colonography, they can find your site on this website. I see another question. How many CT colonography exams do you perform monthly that your navigator submits data on? I can just speak to at Emory. We perform typically 3 to 4 CTCs a week. So gosh, that puts us at what, about 12 to 16 a month that we're doing. Other panelists, feel free to chime in.
We average about 8 to 10 at UT Southwestern.
Got it. Thank you.
I just joined Boston Medical Center a year ago, so it's not really fair to say what our data was for the last year during the pandemic. But prior to that, I think when I was down in Rhode Island, we were doing on average 1 a day.
That's fantastic. And I see where Nancy has put into the chat the link for the CT locator tool. So thank you, Nancy, for doing that.
There's another question. What practical tools with GI docs were utilized to engage endoscopists at UT Southwestern or Emory in reference to the question?
Do you want to go first, Dr. Vassan?
So we, not sure if we have any particular tools, but we met with them. I think starting the getting the buy-in from the gastroenterologist by making it a screening program that we want to just increase screening, and both departments work together towards it. So as we said, we have Thomas, who actually is a bridge between the two divisions, so that has helped a lot and actually has helped increase our CTC volumes. And so we offer the patient optical colonoscopy as a first choice if they are, if they don't want to do it, or if he perceives them to be a little uncomfortable, then he will then also give them the option of CTC. And so our gastroenterologists are fine with this workflow, and this has actually increased our numbers over the time slowly.
Thank you, Dr. Vassan. What we did at Emory, so our radiology department chair, Dr. Carolyn Meltzer, had the great idea to create a task force, a colon cancer screening task force with membership representation from the gastroenterologists as well as us abdominal radiologists. And so as we were attempting to grow CTC, we had a series of meetings with our gastroenterology colleagues to talk about the preps, talk about patient flow, that sort of thing, to really get buy-in from the GI doctors as well. It sounds like our experience is somewhat similar to UT Southwestern in that it seems like a lot of our patients we get a lot of folks who had incomplete optical colonoscopies, and we offer a workflow where they can have a completion CTC the same day, which is very popular with our endoscopists, because of course it's frustrating for both them and the patient if the patient went through the prep, but they were unable to see the whole colon. So for those patients, we've got a workflow where they come to radiology. We have them drink oral contrast as a tagging agent to tag any residual fluid, and then we do the CTC on them 2 hours later. So that's been a way to get our foot in the door. That's kind of a win-win all the way around. And then also probably we do a fair number of patients as well that were just either didn't want the optical colonoscopy or were thought not to be good candidates for it. But I think that task force really helped at the beginning, just to let our gastroenterology friends know that we were starting the service line and to figure out how we could be most helpful to our patients.
Yeah, at Boston Medical Center is exactly the same thing. I gave a grand rounds to GI last year just to let them know that we're still around and that we're doing this. And we try to make it as easy as possible for them to refer their same day incomplete colonoscopies to us. I think that's the best place to start, just to get the GI docs comfortable and confident in the abilities of CTC for screening purposes, and then you can open up the conversation to the primary care providers as well to refer their patients that may not want to get or may not want to start with a colonoscopy. And we do the same 2-hour prep protocol in terms of tagging. In terms of laxatives that we use, it's the same laxatives that the endoscopist can use for their colonoscopies will work for CT colonography as well. Although I think if given the choice, if they are prepping specifically for the CT, I'd usually recommend one of the lower volume preps like magnesium citrate. So I think it's better tolerated than the higher volume preps like Go Lightly.
Yes, and we also, thank you, Dr. Chang, we also worked in collaboration with our GI colleagues in thinking about the preps to use for our CTC. And we have chosen to go with the polyethylene glycol based prepped, or Miralax would be one of the trade names for that, just because you don't have to screen for kidney function. And it's considered to be safe in everyone. But yeah, that was also great to establish the relationship with the GI docs to get their input on preps and that sort of thing too.
All right. Here's another one. Do any of you offer same day FU colonoscopy for positive CTC?
We don't at this time. That is a question. Yeah.
That would be the perfect situation to be able to do that. I know at it sounds like at University of Wisconsin they do that. It involves having a radiologist be available for an immediate read. So if you have the workflow and the setup where CTCs can get read immediately and a decision can be made same day to refer to colonoscopy, and then if you have gastroenterology available to open up a spot for a same day, that would be the perfect situation. But I think most places I've seen have yet to coordinate to that level, but that doesn't mean it can't be done.
I will share with you all what I learned literally last week from Dr. Abe Dockman at the Society of Abdominal Radiology meeting. Is the way that they're doing it at Chicago is when they schedule the patient for their CTC, they ask the coordinator asks the patient, would you be interested in a same day optical colonoscopy if something is found? And Dr. Dockman said that surprisingly, actually, a lot of patients are not interested in the same day completion optical colonoscopy, but for those that are, then what they do is they double book the patient for both the CTC in the morning and then the optical colonoscopy at some point after 12 noon to make sure they got plenty of time to read it. And so then by double booking in advance, then the patient has already gone through the pre-cert for the optical colonoscopy. So you're not scrambling to do that the day of the CTC if the CTC is positive. And then if the CTC is positive, then the road is paved and they can go on to their optical that afternoon. And then if the CTC is negative, the optical colonoscopy is canceled. So we've started, and I see Luciana's on the call, and Lucian, sorry to spring this on you, but we have started discussions with the GI doctors at Emory to try this workflow to see if we could work something out, because you got to get buy-in from your GI colleagues that they would be okay with having a colonoscopy booked that may get canceled if the CTC is negative and if they don't need the optical colonoscopy. So I think that just seems like a really neat way to do it, where you can do it in a controlled fashion in advance, double book both exams. So if the CTC is positive, the patient can go on to the optical, but if the CTC is negative, then you can cancel the optical, is one way to do it.
Okay, so I think we can go ahead and move on from Q&A and start wrapping up. We don't have any more questions coming in. So I just wanted to give some reminders about some of the things that we talked about today, and also just remind you about our upcoming webinar. But if you are interested in the NRDR knowledge base, there's a link here, and we will send the slides out to everybody along with a recording of this webinar afterwards. So you can click any of these links if you want to when we email you. But the NRDR support knowledge base is where you can find all sorts of information about how to submit data to CTC, how to use your reports, and so on. We also would love if you could follow this link to our survey and give us some feedback on your experience with CTC. So again, when we send these slides out to you, just click that link and you can fill that survey out. Part 2 of this webinar series is planned for May, so it's just a couple months away. We'll get back to everybody shortly with a registration link and a firm date for that. So anybody that has attended or registered for this webinar, we'll make sure you're on the mailing list for that one as well. And that one is going to be titled Getting Started with the CTC Registry from Enrollment to Data Entry. And finally, if you're interested in claiming CE credit, there's some information here. You'll receive instructions within the next couple weeks from a LeCount at acr.org. That's Alexis LeCount, who's part of our education department here at ACR. So just be looking out for that email link, and that will give you more information on how to claim your credit. And the deadline for claiming credit will be Wednesday, June 30th, 2021. And if you have any questions about it, you can email Alexis and she'll help you out. So with that, I want to say thanks everybody who was able to attend, and we hope to see you for part 2. And thanks to all of our speakers. Have a great day.
Thank you.
Thank you.
Thank you.